Welcome to the Spark Live webinar series, one component of our Spark Knowledge Mobilization Program. Spark is Children's Healthcare Canada's shared platform for advocacy, research, and knowledge. Spark Live is where we gather each week to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community. Our goal is to spark conversation, ideas, and action. Children's Healthcare Canada would like to thank our funding partners for their ongoing contributions that support all of our programs and activities, including this Spark Live bi-weekly webinar series. There are two options to join in on the live conversation. Questions and comments for our panel or presenters can be typed into the question box, or comments that you want to share with the audience can be typed into the chat box visible to all of our attendees. For those of you on Twitter, tag @ChildHealthCan on any webinar-related tweets or use the hashtag SparkLive. And to keep up to date on all of Children's Healthcare Canada's webinars and other activities, be sure to sign up for our weekly Spark News e-bulletin by visiting our website at childhealthcan.ca. Hello everyone, and welcome to another edition of Children's Healthcare Canada's Spark Live webinar series. The Spark theme for November is Child Health Potpourri. I'm Paula Robson, your host for the next hour. I'll begin by acknowledging that Children's Healthcare Canada operates on the traditional and unceded territory of the Algonquin Anishinaabe people. We recognize and deeply appreciate their historic connection to Ottawa. And today, Ottawa is home to Indigenous peoples from across Turtle Island. Children's Healthcare Canada is committed to working towards forging new and deepening existing relationships that include First Nations, Inuit, and Métis peoples, and is grateful for the opportunity to share this land as we work to measurably improve children's health outcomes from coast to coast to coast. We're speaking today with Sasha Litwin, Lindsay Clark, and Jocelyn Copeland to bring you Can a Room Reduce Pain? Co-designing hospital spaces with children, families, and the healthcare team. I will introduce our speakers for today. It's my pleasure to introduce Sasha Litwin, an associate professor in the Department of Pediatrics, Temerity Faculty of Medicine at the University of Toronto. She's an attending physician in emergency medicine at the Hospital for Sick Children. Her research uses human-centered design methods to generate novel solutions to challenges in the emergency department and the experiences for children and families. She's obsessed with the intersection of art and science and how to foster creativity and humanity in healthcare providers. Lindsay Clark has 18 years of experience working in the healthcare field and brings expertise in human-centered design, strategic foresight, and systems thinking to understand and solve complex problems. Lindsay is the director of HR optimization and design and volunteer resources, where she applies co-design methods to improve the staff experience and design more human-centered HR processes. Lindsay's interested in how collaborative human-centered design processes and the application of future thinking can support the development of innovative solutions to improve experiences and outcomes and a more people-centered health system. And Jocelyn Copeland is the program manager for innovation and design at Sick Kids. Jocelyn has a background in occupational therapy with over 20 years of clinical experience, and she now specializes in healthcare innovation and holds a master's degree in design in strategic foresight and innovation. Jocelyn brings human-centered design and innovation strategy to teams across Sick Kids and co-designing better healthcare experiences with children and families. It's my pleasure to pass the mic to Jocelyn.
Thank you so much for welcoming us. Good morning, everyone. Before we begin talking about how human-centered room design can reduce pain, I would like to acknowledge the happy coincidence that we're giving this talk during National Pain Awareness Week. We hope you'll have some takeaways that can be applied to minimize pain wherever you are working. I would also like to acknowledge our team of designers, because we're really lucky at Sick Kids to have three clinicians with this specialty master's design that we can apply in our healthcare setting. So you'll hear from each of us throughout this presentation. And next, I would like to present Tyler. He is my son, and he said I could share this story with you about some experience he had as a patient. While I talk, I invite you to think about the impact of the physical space on his experience. Whether coming for a routine procedure or something completely new and unknown, there are many factors that help ensure a smooth, safe, and successful treatment procedure. It is common to think about providing instructions and information, possibly a reminder phone call in advance, but we don't often think about the impact of the physical space in helping things run efficiently, helping patients feel calm and less afraid, and ensuring we do no harm. Tyler's a typical teenage boy who was launched into the healthcare system when a lump in his neck turned out to be cancer. The diagnostic process had us in and out of a wide variety of inpatient, ambulatory, and clinical spaces, none of which seemed designed to meet the needs of a young adolescent filled with fear, anger, and some misunderstood hypersensitivities. The lights were bright, the sights and sounds were exclusively clinical. Some rooms were very crowded with clinical equipment and supplies. Some were alarmingly bare and stark, and some seemed to be trying to appease the need for distraction with some toys or TVs, but none provided Tyler what Tyler needed, which was some control, some sensory calming, and access to age-appropriate distractions. Tyler's fear and big imagination would often override his ability to calmly express his needs. He would describe the experience of a needle poke as if being impaled. Nothing in or about the room gave him an opportunity or outlet to express himself. His fight or flight instinct was on high alert. At times, the room housed an Xbox, but it wasn't situated so that Tyler could play his beloved NHL game in a position that enabled the nurses to carry out the necessary procedures. He needed the distraction of the game to cope with what was happening, but his intense focus on the game, rather than the procedure at hand, was misunderstood and misinterpreted. It was turned off. Tyler lost his distraction. He lost the only calming feature in the room. He lost the one element of control he had. The result was a battle ending in preventable harm. The rooms were no better designed for the parents. The only indication that parents had been considered was a chair or two crammed in wherever it might fit. The chairs were never comfortable nor ideally positioned, nor able to hold a parent and a child together, which would have made it much easier to offer comfort and distractions to a child during procedures. Every room seemed to bear new challenges. Every time a clinician had to leave to go get something because it wasn't in the room, his anxiety escalated and the procedures took longer. Despite their clinical look and feel, the rooms didn't seem to be designed for the clinicians either. If the rooms didn't work for the patients, the parents, or the clinicians, who were they designed for? On top of being impractical or uncomfortable, the rooms tended to elicit a feeling of how we feel doesn't matter. Someone once said to me that people go through awful things and receive terrible news in these spaces. They could be painted in gold and it wouldn't help. I can't help but think how differently we might have felt if the room was painted gold. Might we feel important, regal even? Might it spark our imagination, take us out of this stark room into a kingdom filled with gold? What if there was more to look at in that room? What if the chairs looked and felt like thrones? What if Tyler wore a crown which enabled him to decide how things would go today? What if the king decided the Xbox stays on and we figure out the rest? I think a gold-painted room or human-centered designed room says, we have thought about your fear and your pain, and we want to make it better because you matter. I'd like for you to have a look at one of our treatment rooms, and I'd like you to consider your sensory experience as you go through this space. What can you see in the room? What is on the walls, the floor, and what are you looking at from the patient's perspective? What can you hear in the room? can you identify what is making noise? What can you touch? How do things feel? And how does the room smell? What is making it smell that way? And how does a room make you feel? What is it about the room that makes you feel that way? So we can't imagine that the room was actually intentionally designed this way. As many of the rooms we come across do, they just kind of over time, as we accumulate things, they just become this way. And eventually we just kind of stop seeing what is there and what isn't there, and what might be experienced as scary or unwelcoming. So if you consider the things in this room, what might make a child feel scared or anxious, or how their pain might be heightened by the fear or lack of calming features? Are there simple things we could do to improve this room? There are obvious answers that can feel like common sense, yet we've been using this room this way for decades. Is it a healing environment for a child? So today we're going to share how we used co-design to inform the design of better healthcare spaces, and share the design features that can be incorporated into the space to reduce children's pain and anxiety. We know from research that the built environment influences the way that we feel and that the way we perceive pain. Studies show that our environment can reduce pain and improve healing. We have evidence for the past 39 years with an early study that shows that adults who had a view of nature after gallbladder removal surgery recovered faster and needed less pain medication compared to those who had a view of a brick wall. A study 10 years later shows that patients with images of nature had less post-operative pain and anxiety. Good design matters. If the environment is not designed to address patient needs, procedures may take longer, patients may have increased pain and anxiety, they might require more medication or sedation, safety may be reduced, patients, parents, and healthcare providers may have a poor experience, and when all of this happens, it is more expensive to the system. Lindsay is going to share how we can go about designing better spaces.
Thanks, Jocelyn. So in this work, this is the methodology that our team approached this problem with. So we used human-centered design as our sort of problem-solving methodology. And we looked at design in healthcare and how design methodology can really be incorporated into designing physical spaces. So just very quickly, and we're not going to spend the bulk of our time today talking about what design is, but essentially design, also called user-centered design, human-centered design, design thinking, it is a user-centered and collaborative approach to solving problems. It's one that is creative, it's iterative and practical. It's grounded in developing empathy for the people that you're designing for. And it is a structured process, but it does allow for flexibility and really accounts for the context that helps you really develop this very deep understanding of the problem you're trying to solve from the user's perspective. And so in this work, we essentially went through these main design phases where we looked at what do people want and need out of these spaces. We used some of our creative tools from design to help participants reimagine what these spaces could look like. And we had them prototype, so build low fidelity prototypes to help us test ideas. So in terms of empathy and trying to understand what people want and need, we went to the source. And so to find out how kids experienced these spaces, we worked with our Children's Council and did a series of exercises with them. We also talked to people who had previously been patients in the hospital and to understand their experience. And then we held a series of workshops, which we'll talk about more. So in the interviews with former patients, here are some of the things we heard. So it's important that there's softness when you walk into a procedure room. Make it less scary. I look at everything when I'm in the space. Give me something to look at. It felt like an old place with old equipment. I would have expected something more kid-friendly, more modern. It was a calming experience. It's quiet, lights aren't intense, it's not overstimulating. You can find time to breathe. So only one of those experiences really speaks to a positive patient experience. And when you think about the photo we showed earlier, I think those first three comments from former patients definitely resonates. We went to our children's council and we held a workshop, design workshop, where we took them through a journey mapping exercise, essentially to understand what their experience has been coming to the hospital for procedures. There's a lot of small print on here, so I don't expect you to be able to read it. But essentially through this activity, we went through the major phases of coming to the hospital for a procedure or a treatment. And we asked our children's council, what are you doing when you're in each of these phases? What are you thinking about? How are you feeling? And then we really asked them about their pain points. So what's hard during each of these phases? What bothers, annoys, frustrates you? To really understand what the challenges were with this, with coming to the hospital for these procedures or treatments. Out of this journey mapping exercise, we developed a series of insights that helped inform the development of our design workshops. And so what really stood out to us was that for patients, the journey of a painful procedure begins well before they arrive at the hospital. So it's not just about walking through the doors of the building and the physical space, but it's about the anticipation that patients feel coming for these types of appointments. So they feel anxious throughout the entire journey. And that includes up until after the procedure when they're back at home waiting to find out results. We heard from our Children's Council that the anticipation of the procedure can be worse than the procedure itself. That coming to an appointment at SickKids is a major disruption to their lives. Missing school was a significant stressor, especially for youth who are in high school. And unknowns and a lack of control really exacerbates anxiety around procedures. And I think that really resonates for us and certainly from Jocelyn's son, Tyler's experience as well. And just we heard that the environment is physically and psychologically uncomfortable. And some of the quotes we heard were, I can't help but picture what's going to happen. What will the room look like? Will I know the doctor? I play out the procedure in my mind. Leading up to its worst and actually coming for the visit. There are drawings on the walls of body parts that are not great. That can be really scary for little kids. The rolling paper on the exam tables sticks to you, rips, and is just awful. So with these insights, we held a series of workshops where we posed this question. How might we design outpatient procedural treatment spaces to promote adaptive responses to pain and support psychological, physical, and pharmacological interventions that minimize pain for children? And I just want to take a moment to talk about how might we, which is how we frame our challenges in a design methodology. And it's very intentional. So the how is about opening up the possibilities, saying there are multiple ways to solve this problem. Might really asks us that, again, there are lots of ways, and that brainstorming is really going to help us get to the solutions, potential solutions. And the we is very intentional. So in design, we really talk about design being a team sport, or collaboration being a huge part of design solutions, and coming up with the best possible solutions to your challenge. So we held a series of workshops where we really pushed people to come up with innovative solutions to this challenge. We held 2 different workshops, one virtual and one in person. We had really great interdisciplinary participation, and we also had family advisors participate in some of these as well. So in our virtual workshop, We asked, in one word, how would you describe current treatment rooms at SickKids? And here's what we saw and heard. Small, crowded, old, and cramped, scary, unfriendly, full of stuff, too small. And then we asked, what should they look like? And we heard welcoming, warm, practical, distracting. We also asked our workshop participants to use a design tool called extreme users, where we think about either end of the spectrum of patients who, in this case, maybe who've never come to the hospital before, or patients who come very frequently, sort of every week for these types of procedures. We also asked our workshop participants to think about patients with neurodiversity, patients who have a hearing impairment, whose preferred language is not English, patient who uses a wheelchair, and as I said, patients who are coming for the first time or who come very frequently. And each workshop group was given 2 extreme users to generate solutions for. And we also asked in our workshops for participants to prototype. And this looked very different in terms of how we asked people to prototype in the virtual workshop versus the in-person workshop. And essentially, prototyping is just bringing your solution or your idea to life. And that can be very low fidelity, low cost. You can see, obviously, a cardboard camera here where you could hand that to somebody and you could get feedback from them very quickly on the size, the feel, where the functionality is. They could give you a lot of great feedback on the design of that camera. The photograph on the right is from a workshop that I ran with a team here in our NICU, where we were trying to improve communication between our families and our staff, particularly during rounding. And one of the things we heard from families was that the groups are large and they often have no idea who the different staff members are. And so we created these low fidelity prototypes of badges that could go behind your staff badge, where it would show the role very clearly, so that families could remember or could identify very quickly which role each staff member in the rounding was playing. So these things don't take a lot of time, they don't cost a lot of money, and they're very useful, again, as I said, to get feedback from your users. So you can see some photos from our workshops of folks prototyping. The solution you see here is an app where patients are able to sort of set the preferences for the room when they're ahead of coming for a painful procedure. So we know how to set up the room for each patient. You see this basket on the left, which is an idea where we would have a set of a patient's favorite things that they could keep for patients who come frequently to the hospital, a cubby with some of their favorite distractions, things that would make their procedure more comfortable. The one in the middle is a projector that would project different scenes of a patient's choosing onto the ceiling, so that when they're laying down, they have something to look at. And the one on the right is a prototype of a chair where a patient could sit with their caregiver to have that procedure and be positioned in a way that's most comfortable for them. In our virtual prototypes, we asked participants to find images online that depicted their ideas. And we had some really beautiful imagery that represented different groups' ideas in terms of having an environment that is warm and welcoming and allows for distraction. We won't go into too much detail, but this is essentially the data that came out of our workshops, our interviews, and our journey mapping with our Children's Council. And as a team, we really worked to converge all of this data to generate some recommendations, which I'm going to hand over to Sasha to walk through our findings.
Thanks. So now to the results. And we hope in sharing these results that we can help you use some of these ideas to improve the spaces where you work. So I'll go through each of our results and some of the literature that supports it. So the first really important theme that we discovered was control. So having a sense of control reduces anxiety and fear. We probably see this all when we're working with patients. So the space must be designed to give patients and healthcare providers some control over features of the environment, right? So for example, we can ask our patient, do you prefer to watch the procedure or not? Would you like the lights on or off? Even for the healthcare provider or for the patient or the family, do you want to pick the music that we're going to listen to? And when we look to the literature to validate what we found, we find that when patients have control over their body, over what happens to them, they have more trust in the healthcare provider team. The next theme that came up was privacy. So privacy is important to give patients and families control over their body, over their information. And the space must be designed with features to help patients feel safe, secure, and respected. Several of the patients and healthcare providers shared a similar experience with us, that someone would open the door during a sensitive procedure, causing the patient to be exposed. And I find this in the emergency department all the time. I'm speaking with a youth. I say, this is going to be confidential between us. And then I pull a very flimsy curtain across to give privacy. So examples of what you could do in your own space: try to make sure that there's walls, curtains, or doors that ensure privacy for patients. And especially if someone needs to leave to open the door and come back, that there's a way that the patient's not exposed. And in particular, if you're going to have a confidential conversation, it needs to be in a space that's soundproofed and actually confidential. So the next theme we found was distraction. And I know there's a lot of child life specialists here on the call, so we know how important this is. There is tons of evidence that shows how distraction is important to reduce pain and anxiety for children in hospital and for children having procedures. So we must design a space that promotes the expertise of our child life specialists, and obviously only when available, but either way, when they're available or not, to encourage the use of distraction tools that are evidence-based, known to reduce pain and anxiety. And there's so much great literature here about all the different types of distraction, digital technology versus not. So we have to just have this space where there's available distraction tools that are age appropriate, that are easy to use. The next theme that we came up with was how important the sensory environment is. Patients are highly attuned to the sensory environment. What are they seeing, feeling, smelling? So the space must be intentionally designed with those sensory details. And we talked a bit about some of the prototypes, but a lot about it was, how could we personalize a space or a procedure room for children that are coming based on their preferences? Do they want the lights dim? Do they want it to be calm? Do they like a certain color? Could we use that to make the environment feel different for them? And then the next one we found was inclusive design. So children's hospitals are unique. They're unique spaces that have to foster a family and child-centered care environment. And so we must think about spaces that are inclusive for all the different individuals who will use that space. So what does that mean? For example, the language on signage, all the visual communications have to be inclusive of using gender neutral language, inclusive of using translations. The space and how we lay out the space and lay out the furniture, it has to encourage family involvement, because we know how important that is. So comfort positioning, letting a child be with their caregiver during a procedure, before or after. How do we lay out the space so that's possible? And the final thing that came up often was, the space must encourage the use of interpreter services. It must be easy for us to be able to communicate with our patients in their preferred language. The next important theme was organization. Sorry, you could go back a slide. So the healthcare providers, the patients, everyone talked about these cluttered rooms and how it increases stress for the patients and how it's just unsafe or inefficient for staff. So the space must have a standardized organization system, and it must be based on human factors principles. And the best way that I relate this to the world is Starbucks or IKEA or a store like that. So let's say you're going to Starbucks and you want to find a gift card to buy. Even before you go into a Starbucks, you know where it's going to be. You could be in a different city. I could be in Ottawa, I could be in Toronto, I could be in Halifax. I can find it, I can go into the store. And that should be the same for our procedure, our treatment rooms in hospitals and many rooms. The healthcare provider shouldn't have to be exiting and entering to get supplies, to get medications. We shouldn't have to open 12 drawers to find what you're looking for, right? The human factors organization of a space makes it safer. So that's one important part of organization. The second is patients really don't want to see scary resuscitation equipment. They don't want to see anatomy posters with skeletons. So we can remove that, right? We can design a room or cupboards or spaces that where the resuscitation and scary equipment is not immediately in view. And when we looked at the literature to support that, actually there was a randomized control trial that showed that when patients, they looked at patients who have a view of their medical equipment and patients who have the medical equipment hidden from view. And when it's hidden from view, not a big surprise, it actually reduces patient stress and increases patients' trust in their healthcare provider. And the final theme that we came up with is all about the journey. And we've talked about this already. But if we can give patients and families anticipatory guidance about what to expect, it reduces their fear and anxiety. And so it's very important when we're thinking about a space to think about how we can develop materials to help patients and families understand what to expect and to help guide them through the journey. And I'm going to give this example from the Rotterdam Eye Hospital. So they realized that patients and children were very afraid to come to the eye hospital. And they did a series of design experiments to see what would work. And one of their ideas was sending Ubers for the family to come to the hospital, thinking maybe that will really reduce the stress. But that wasn't that effective. The thing that was the most effective was sending the family a package of information about what to expect. And they sent the child a t-shirt with one of these animal prints on it. And when the child came to the hospital, they saw the animal print several times repeated throughout the journey, like in the physical space. The clinic room had the same animal print that they had, and the ophthalmologist, the eye doctor that saw them, had a pin with the same animal. So it's all about like giving markers throughout the journey to say that you're here and this is what's going to happen next. So our next steps. We are working really hard at Sick Kids to create a physical prototype of our room. We're finding the right space to do this. And then we really want to test it. We need to figure out what the metrics will be. How are we going to measure pain and anxiety? How are we going to measure if it's more safe and more effective? And then we're going to improve things iteratively to really make a single prototype. Then we hope to scale to many different procedure rooms in the hospital. And we are doing this decades long renovation. So this is a really important time to say, let's figure out what's going to work. Let's figure out what's ideal. And then how do we scale that in our renovations? And I'll just pass it back to Jocelyn so she can wrap up for us and give us our take-home messages.
Thank you, Sasha. Now that you've gone through our process and understand more about the methodology and our findings, we think back to Tyler's story and consider, what did Tyler need in the spaces he was in? And I'd like to also share that just sometimes when we consider changes, we imagine like, oh, we have to re-renovate and move walls and introduce a lot of complicated IT or things like that, but we don't. Really small changes can make a really big difference. And even in the examples that Sasha just shared with the teachers, like just something small, like moving the position of the TV so that it is accessible during a procedure to play a game. The little things can actually make a big difference. The color of the walls. And we also just want to reinforce that making really low cost, low fidelity prototypes just to test things out is not difficult, and it's worth it. We learn a lot from the prototypes and they just get better and better as we go. So we just wanted to share all of that with you. And we would like to invite everyone to share any comments or questions with all of us. Thank you.
Thank you very much for that great presentation. We've got a few questions coming in. This is also a prompt for those of you who might still have questions to ask, but haven't shared them. Go ahead and type away. We have, how do you tailor the room to balance the need for some patients to have vivid or loud distractions to hold their attention, and the need of other patients who need quiet and calm?
I can take that. And then Sasha and Jocelyn maybe jump in if you have anything to add. I think, what we heard loud and clear from the children that we spoke to, the family advisors, the former patients, as well as the staff, that we need flexibility. These rooms need to be flexible. And so when we think about, loud and distracting, is that, volume that can be toggled depending on what a patient needs. Having the ability to have equipment in the room that, can be a source of distraction, but can be put away in its place after for the child that needs, less equipment around. So I think it's just all about building flexibility into these spaces. I don't know, Joss or Sasha, if you have anything to add.
You can think about things that you can bring into the room and take out of, whether it's things that are like a speaker that plays loud, distracting sounds or music that can go in and out of the room or be turned down, as Lindsay mentioned. But what are some of the other things that we can add or take away without too much difficulty?
One of the things we've tried in the emergency department was just using light, like, using like these, bubble towers or different projections, because as a lot of people are asking in the chat, like, who has budgets for major renos and major like different types of rooms? But adding light can be a very effective way to very much change the sensory input of the room. It can be like white and calm and dim, or it can be like crazy colors moving. If it's okay, I saw a question from Allison Everett that I have an answer to. She asked, is there any research about the difference between real nature images versus artificial ones, computer-generated design ones? Oh, actually, Allison, I think the study, I'm reading your question differently. So there's definitely evidence to show that real views of nature reduces pain, reduces anxiety, reduces medication needs, improves healing. And there's also evidence to say that images, not necessarily photos even, just images of nature has the same effect. But I don't know if there's a study that looks at photos versus, let's say, paintings. And I think that's a good question.
Thank you for that. Christine, I think you responded to her, how do you hide all the equipment necessary so it's not overwhelming, but you're suggesting that there's things we can bring in and take out of the room as well. Do you have any sort of storage suggestions to keep the equipment in there and reduce it being an overwhelming experience for kids?
I think what Sasha was getting at in the piece around organization is that as much as possible, can we standardize the equipment that's in these rooms? And yeah, I think there's probably more equipment often in these rooms than we actually need, which can make it difficult to find what you actually need, or it's not the right equipment in the room. So I think it's really being very purposeful about what that room is going to be used for, what equipment is needed, and then making sure you have storage spaces that can be closed. There's a tool in Six Sigma called 5S where you really like standardize and sort and make sure you have all the right things in the right place and in the same place. So whether you're going into a treatment room in the emergency department or you're performing a treatment in the oncology unit, the rooms are set up in the same way for clinicians so that it's easy to find what you need. You're spending less time looking for equipment, and ideally there's purpose-built storage for that equipment.
Thank you. Yes, because I can see that staff time, feasibility from a staff time perspective, not just in the design and development, but in the maintenance and adaptation of the rooms to individualize them. How burdensome have you found that to be?
It's a great question, Paula, and I'm not sure that we've studied that necessarily, but I mean, from our own practices, as an OT and RN and a physician, we've all had our own experiences working in these types of spaces. There's often a lot of, people think that their needs are unique. And I'm not saying that people aren't unique and doing unique and really highly specialized procedures. Certainly that's the case at SickKids. But I think there's a real opportunity to say, what is the best practice? What is the evidence to support? What is the best way to do this procedure and what's required to do that, so that there is more standardization. And I think it's making the room easy to use for clinicians. That's the selling point, and getting people on board with this, and that will save time if it's easy to walk into the room and know where all the equipment is. That you're not spending time looking for things. That means there's fewer delays in seeing patients on time, in sort of your throughput and in your day as well. So there's benefits, I think, huge benefits from a clinician perspective, and really purposefully designing these spaces.
You've spoken about a bit about feasibility, and that small changes that are low cost, low barrier, make a great deal of difference. For the full process from engagement to design to implementation, who funds it? Roughly, what would a healthcare organization need to budget for such an activity? Did you develop a business case to justify the cost to the hospital that would be useful to others?
Okay. As I mentioned at the outset, we're kind of lucky because we have this knowledge and expertise in-house. And so we were able to do this without a cost to the organization, because we already work there. And yeah, so that is lucky. Without that, I mean, there are things that you can learn, from us, from others. There's there's lots of education sessions and stuff where you can learn some of the methods and some of the elements of design. You can also hire external design consultants who can come and help with pieces or the whole process. And as for where that funding comes from, I think that's probably organization specific.
Okay.
Laura, that has been one of our bigger challenges, like to add to that, right? Like we are very passionate. We're really passionate about the work, and we believe in design as a method. And some of it's off the side of our desk, and some of it's part of our particular roles. But in terms of the implementation, it's definitely a lot of different factors and people passing things around and deciding whose responsibility it is, even to do some very minor things to improve the space. So ideally, if, some examples I've seen is if there's a space that, like, if something's already going to be happening, maybe that's when you slide in, get your foot in the door and say, hey, like, let's use some evidence here. Let's use some co-design here. So that's what we're trying to do.
Right.
But I don't think we have a dollar amount or a business case. It's
okay.
Just like persistent, enthusiasm so far.
Tenacity. Laura asks, they struggle to integrate patient participation into co-design in local hospitals. The designers tend to come in, ask their questions, run off and do a design, and that's either accepted or not at a senior level. Any advice for folks to overcome that?
I mean, again, I think as Sasha said, we're passionate and we truly believe in the power of co-design. And I think, although some of what we probably presented today, especially to those of you who work in children's hospitals, may seem, straightforward, and maybe some of it feels like common sense. I think having it grounded in the insights and sort of the information that came from those rich focus groups with the Children's Council, with former patients, I think there's more weight to it when we present it back to some of our key partners here in the hospital. When we presented back the findings and we're saying, this is what we heard from our patients and from our caregivers and from our former patients. But I do think it does take a willingness of leadership to want to do it. It definitely takes a little bit more time, which often I think we're a little impatient when it comes to improvement in healthcare. And so it does take a little bit more time to slow down. But I would encourage, especially if they're external consultants, I think there's a real opportunity, especially if you're a leader in healthcare, to insist on this being a part of that process. Right. We really shouldn't be designing physical spaces or processes or programs without the input of those who will be using them, who will be treated in them. Mm-hmm. Ultimately, it's their experience that we're trying to improve and their outcomes. We talk about in error prevention, like nothing about me without me. And I would say that holds true for design as well.
That makes sense. We're human-centered and child-centered in our activities. We have a number of other questions, but in the interest of time, I'm going to ask one more, and it relates to audio. So there's two questions that come in about setting up music or audio in the room. One is talking about they have a sound machine and a projector that they need to now order. Do you have recommendations? And the other is, can kids bring their own music or phone players into the room, or is there any barriers to that?
I think in enabling kids to choose the music or be able to play their music is really giving them that element of control. And it's also something that is soothing and calming to them, or distracting and energizing. So I would absolutely say that if bringing their music into the space is a fantastic idea. As far as a particular sound or projector machine, I don't have a brand or name in mind, but there's lots of them that are available, and pretty inexpensive ones that, project all sorts of different stars and lights and things on the ceilings and the walls. You can find them very easily online. I don't have a particular brand. I don't know if anyone else does.
No worries. So that's thank you so much for all your questions. Thanks so much for your feedback. And that's the end of our time together today. Thank you to Sasha, Lindsay, and Jocelyn for sharing your time and expertise with us. Thank you to our audience members for joining in. We know how busy you are all right now, and we hope you depart with some practical knowledge to bring back to your organizations. Upcoming in our Spark Knowledge Mobilization Program, still in November, we're on November 27th, we're bringing you the next episode of Spark Conversations, our podcast series. Subscribe on your favorite platform and listen to Navigating the Child and Youth Mental Health Crisis, Challenges and Opportunities, where Dr. Catherine Smart speaks in conversation with our special guest, Dr. Javid Sakara. In December, of course, we have our annual conference, Flip the Script, High Performing Health Systems for Children, happening on December 3rd to 5th at the Hyatt Regency in Vancouver. Associated with that conference is a transitions pop-up event. The Child Health Hub in Transition to Adult Healthcare is hosting this pre-conference event, Ready, Set, Go, Finding positive solutions to support a successful landing in the adult world. And that'll take place on December 2nd and 3rd, also at the Hyatt in Vancouver. I hope you can join us there. There are also virtual options if you're unable to attend in person. It's always great if you can watch live, as your questions and comments really enrich the discussion for these webinars. But if you can't, the recordings of these sessions are made available after the fact on our website. Thanks again for joining us today. Thanks to Sasha, Lindsay, and Jocelyn for this presentation. And hopefully we'll see many of you back here soon. Bye for now.